very good afternoon. I'm going to speak on the topic chemical injuries of the eye and its management. So the background is it accounts for 20 to 30% of ocular injuries, 10 to 15% of occupational injuries, and the worldwide data by the Labor Statistics of America, it says that 1.6 million people who have become blind because of chemical injuries, 2.3 millions who have become bilaterally visually impaired, and 19 millions with unilateral visual loss due to eye injuries. This data is really alarming because we always say that chemical injuries can be treated, but if it's treated, why this data is so alarming for us? So what happens is, when the corrosive substance is accidentally introduced to the eye or the preocular tissue, then it causes the chemical injury. And most prevalent among the young males, aged between 20 to 40, but we should not forget that children are also at risk. Exposure can occur at home, at workplace, and in association with criminal assault. The most important thing we have to understand here is it's a true ophthalmic emergency. We need an immediate and intensive intervention to minimize the complication and profound visual loss here. So you'll be alarmed to see that the most common offending agents are present in our work and home, like cleaning solutions, drain cleaners, oven cleaners, bleach, battery explosives. And the industrial agents are the alkalis and the acids. So when we see patients and we don't know what is the cause of the injury, you can always ask for the source. So these are the source, like industrial cleaners and the battery acids are the source for sulfuric acid, glass polishing, glass frosting, gasoline, alkaline, they are the source for hydrofluoric acid. Vinegar is the source for acetic acid, and fruit and vegetable preservative and bleach. So you will come to know that what kind of injury your patients are having right now. And the source of alkaline are also there. So these things are available at our disposal at home or workplace. That's the reason these accidents are pretty common in our day-to-day life. The severity determinants are the pH of the material, the specific reactivity with tissue, the concentration of acid and alkali, the volume, the temperature, and the impact force. So just to discuss that, what will alkaline and acid substance do to our eye? So in alkalines are lipophilic, so they saponification of cell membrane. So there's a rapid and deeper penetration to the ocular tissue. In acid substance, they coagulate the protein of ocular tissue. So they coagulate the epithelium, and epithelium acts as a barrier, and which limits the further penetration. So by this, you will see that maybe the alkali injury is more deeper, you will feel it is more serious. But no, the acid injury is equally serious, though it is not deeper, but it's equally serious. So alkali injuries occur more frequently than acidic injury. Both alkali and acid exposure can lead to devastating injuries. So because most of us are here doctors and paramedical staff, and you are getting a lot of patients with the chemical injuries, here what we will see, if the patient come to us, these are the signs which we have to look for. They are the periorbital edema, erythema, de-epithelialized skin around the eye, loss of eyelashes and eyebrow, conjunctival epithelial defect, corneal epithelial defect, chemosis of conjunctiva, conjunctival inflammation, limbal ischemia, cloudy cornea, and edema of the ocular tissue. So the most important prognostic factor immediately after the ocular injury is the extent of ocular surface damage. How much surface is damaged? And that is, this extent is initially reflected by the limbal ischemia, and which leads to the secondary limbal stem cell deficiency. So here, because a lot of people might not understand why limbal ischemia and the surface is important here, because limbus is the area of the eye where our stem cells reside. And as we all hearing about stem cells these days, these are the pluripotent cells which will just renew your eye again. In the common terms, they are renewing your eye again. So when these damage happen and our limbus are getting damaged, our stem cell are also getting damaged. And that is why our eyes are not getting healed. So that is why it is a very, very important prognostic factor that how much stem cells are there to heal our eye. So when the patient comes to you, it's very important if you're dealing with the patient to classify patient to assess the prognosis in future, that what will happen to this patient in future. So the classification element, the most important thing is to see the limbal involvement at the time of injury. Studies have shown that the relative proportion of surviving limbal tissue is a major prognostic factor. As I discussed before, it is because of the stem cells. So the accepted classification for chemical injury is the Roper Hall classification. It divides the chemical injury into grade 4. This is well accepted classification in the clinic, and you can classify your patient according to these grades, and then you will know the prognosis of the patient. In grade 1, the prognosis is very good, and in grade 4, the prognosis is very bad. And it take into account limbal ischemia and the corneal involvement. In grade 1, there is no limbal ischemia, but the corneal defect is there. But in the grade 4, there is a great amount of limbal ischemia, and even the cornea is so opaque that you cannot see the details of the eye. So these pictures might help you to understand this. The first picture, this is the pointer. The first picture, you can see the details of the eye. You can see iris and the pupil, but the limbus is also looks healthy. So this is a grade 1. But if you see the fourth picture, you cannot see the details here. So that means the limbal ischemia is like 360 degree and the details are not visible. So these kind of cases have a very bad prognosis. And another well-accepted classification is Dua's classification. It takes into account the limbal involvement into clock hours and the percentage of conjunctiva involvement. So they divide the cases into 6 categories. This classification shows that grade 1 has a very good prognosis and there is no limbal involvement and no conjunctival involvement. But grade 6 has a very poor category and the limbal involvement is 12 clock hours, and then the conjunctiva involvement is also 100%. So if you see these pictures and the first picture, so the limbus is all looks healthy, but in the last picture, everything is involved here. So it decides the prognosis. Very important to classify in the clinic. So both the classification are well accepted. In first classification, we take into account limbus and cornea, and in the next classification, we take into account limbus and conjunctiva. So who are the people at risk? They are housekeeping staff, laboratory workers, service laboratories, and the factory workers. 60% of chemical injury occurs in the workplace accidents. The course of injury, why it is important to discuss here, because the management differs with every stage of chemical injury. So when we go for the pathophysiological phases, then the immediate phase is there. Acute phase runs from 0 to 7 days. Early repair phase 7 to 21 days, and late repair after 21 days. And depending upon these phases, the treatment differs. In acute phase, what happens? The tissue reestablishes the superficial protective layer of corneal epithelium. Modulation of stromal regeneration and repair keeps happening. Significant inflammatory mechanisms begin to evolve on the ocular surface and inside of the eye. The IOP rises by model here. In early reparative stage, which runs from 7 to 21 days, the chronic inflammation starts, stromal repair and scarring happen. This stage is very, very important because corneal ulceration tends to occur at this stage. In late reparative stage, after 3 weeks, so it is characterized by completion of healing with a good visual prognosis if the injury is grade 1 and 2, according to Roper Hall, and if a complication will happen in those with a guarded visual prognosis in grade 3 and 4. So the management depends upon the stage of the disease, and the management also categorized into immediate management, acute management, which is less than 6 weeks, and chronic management, which is more than 6 weeks. So this is important for us. If a chemical gets into your eye, what is the first thing you should do? And I think we have a lot of paramedical staffs also here. Is there any, are you getting patients who are getting chemical injuries in your settings? And anything you are doing are you taught to do any first aid in those patients? I think all the patients are referred to ophthalmologist here. Okay. So the first thing is, should not delay the treatment. So we should always assess the extent of damage, the type of chemical went into the eye, the amount of chemical, the pH of the chemical, duration of contact. But if you're not getting this information, the treatment should not be delayed. That's most important. The goals of management would be, first thing is we have to remove the offending agent. We promote the ocular surface healing, controlling inflammation, reparative procedures, and prevention of complication. These are goals of the management. In immediate phase, we just have to thoroughly irrigate the surface to remove the offending agent. The copious irrigation with the balanced salt solution or ringer lactate or minimum or anything available at your disposal, at least minimum from 20 to 30 minutes under topical anesthesia should be done. And at the site of accident, tap water is still okay to use, but you should use whatever is available at your disposal. And after 2 liters of irrigation, use the litmus paper if it is available and check the pH and continue to irrigate until the pH is 7.5, that is a neutral pH. Okay, so then if you're getting a neutral pH, that means you have removed the most of the offending agent. And this is a way how we double evert the lid just to see that if there are any kind of particles left in the fornix, and you can double evert the lid and check yourself. These are the Morgan lenses which are not available everywhere, and it is not available even in the very well equipped hospitals. But these Morgan lenses, they have a continuous delivery of saline, like water. So you can put this in the eye of the patient and keep irrigating the eye of the patient. So if it is available, you can always use it. It is very easy to use. So in short, the management of immediate phase contained, you can use tap water, you can use any buffered solution available, you can use purpose designed solution or amphoteric solution, but just irrigate the eye as much as possible and check the pH. This is a mainstay. The caution. In case of pediatric cases, if the examination is not possible under topical anesthesia, it should be done under general anesthesia, though it should be done under supervision of ophthalmologist. So now we have an acute phase. I hope it is visible. Yeah. In acute phase, the main things we have to take care of, that we have to reduce the inflammation. For that, we use corticosteroid. We need to stop the stromal breakdown. We need to stop the ulceration of the cornea. For that, we can use tetracycline citric acid, ascorbic acid, that is collagenase inhibitors. And we need to promote the epithelial repair. So for that, we can use the bandage contact lens, amniotic membrane transplantation, autologous serum, or tenoplasty, and treatment of the higher intraocular pressure. So this is a summary. So we are promoting the reepithelialization and decreasing more ulceration and stromal keratolysis. We are controlling the inflammation, and we can use preservative-free tear substitute, bandage contact lens, and topical steroid is a mainstay, but if you see that cornea is thinning or melting, we should stop it right away. And consult ophthalmologist as soon as possible. This is a summary of, this is a flowchart what we use in our clinic, and it is just a summary of both the slides here. In chronic phase, the main thing is the restoration of our eye, the restoration of fornix and the eyelid, the management of limbal stem cell deficiency, which should not happen, and the management of glaucoma. So we have a number of steps what we follow here, and the surgical treatment to assess the chronic stage and treat the patients here. So I'm not going to discuss a lot of surgical techniques in the chronic phase, because I don't think so that connect our topic here. So we'll discuss what can be the side effect if the patient is not getting a right treatment on a time. And even if the patient get the right treatment on a time, these can be the sequelae of chemical injury. It can be a profound vision loss. It can be corneal scarring. Xerophthalmia means dry eye. Simlifron, enchylobrephron, and the long-term complication can be glaucoma, uveitis, cataract, and the lid abnormalities like leg ophthalmos, entropion, ectropion, and trichiasis. So you can end up in these kind of eye if we are not treating them well, or if the patient delays a treatment. So to conclude, chemical burn is a serious ophthalmic emergency where immediate action is required. And thank you very much for your attention. I hope I have not increased your food coma here. Thank you very much.